Assalamu alaikum wa rahmatullahi wa barakatuh. Our lecture is about the operative intervention in obstetrics by Dr. Ragad Abdul Halim. The objectives of this lecture is to outline about most common obstetrical operations with their definition, types, indications, and possible complications, including perineal tear, instrumental vaginal delivery, cesarean section, cesarean hysterectomy, and hematomas. The best outcome of pregnancy is a healthy mother and baby, ideally following a normal vaginal delivery with an intact perineum. Sadly, for many women and babies, the hazards of childbirth are a serious risk. Indeed, operative intervention to manage these hazards has come to be regarded as a mainstay of safe motherhood. The first subject is perineal tear. By definition of perineal injury, we have 4 degrees. The first degree involves skin only. Second degree involves perineal muscle and therefore include episiotomy. So, episiotomy is an iatrogenic second-degree perineal tear. Third degree, it is a second-degree tear with disruption of anal sphincter, which is further subdivided into 3A, 3B, and 3C. 3A when less than 50% of external sphincter thickness torn. 3B when there is more than 50% of external sphincter thickness torn, while 3C when internal anal sphincter also torn. The fourth degree is a third-degree tear with torn anal epithelium. This figure shows the degrees of perineal tear. Repair of perineal tears. Some first-degree tears will not requiring repair, and others will simply require 1 or 2 interrupted sutures. Second-degree tears or episiotomy is sutured in layers by opposing the vaginal epithelium, perineal muscles, and skin. While in third and fourth degree tears, disruption of anal sphincter will result in retraction of muscles or muscle ends. Therefore, adequate muscle relaxation with regional or general anesthesia is essential. Why? Because the anal sphincter is in a contraction state at rest, so it appears as dimples at both ends of tear. It is difficult to suture it in a resting state, so this is why we require a muscle relaxation with a regional or general anesthesia. The repair is done either by end-to-end technique by approximating the two muscle ends or by overlap technique. Both techniques have the same outcome. Antibiotic and laxative agents are prescribed to prevent secondary infection and constipation. Complications of perineal tears. First, missing the apex of a tear or an episiotomy may lead to continued bleeding or development of paravaginal hematoma. Second, deep sutures involving rectal mucosa can lead to fistula, rectovaginal fistula formation. Third, tight sutures can lead to significant later discomforts. Fourth, malaligned repair can lead to distortion in the healing and increased scarring or dyspareunia. And finally, up to half of women who sustained a third or fourth degree tear develop bowel symptoms, including fecal incontinence, even in good hands. So you can see it is a big number that may have fecal incontinence from those who sustain third and fourth degree perineal tears. Instrumental vaginal delivery. By definition, it is a delivery of baby vaginally using an instrument for assistance. Instruments could be ventouse and forceps. Indications for instrumental vaginal delivery. We have fetal and maternal indications. Fetal indications include fetal head malpositions like occipitolateral and occipitoposterior. Second is fetal distress. Third, forceps can be used in delivering the aftercoming head in vaginal breech delivery. The maternal indications include maternal distress, exhaustion or prolongation of the second stage of labor. The second maternal indication is medically significant conditions like aortic valve disease with significant outflow obstruction, myasthenia gravis, or severe hypertensive disease. Prerequisites for any instrumental delivery. يعني نقدر نعتبرها هاي الشروط المتوفرة في كل مريضة حتى نقدر نستخدم لها instrumental vaginal delivery. These are confirmed rupture of the membranes. The cervix must be fully dilated except in second twin and cord prolapse with 9 cm cervical dilatation. These are the two exceptions only. Vertex presentation with identification of the position. Position means occiput anterior, occiput transverse, occiput posterior. I have to be sure about the position of the fetal head. Engaged head and the station of the presenting part should be at least +1 station and more below the ischial spine. It means deeply engaged head, adequate analgesia and anesthesia, empty bladder and no obstruction below the fetal head, for example, pelvic kidney or ovarian cyst, to be sure that the head can go down easily. Experienced operator, an adequately informed and consented patient. So the patient should be informed about the indication and the complication of the instrumental vaginal delivery and should be consented about its use. For forceps, in addition, the blades of the forceps should be checked before application for matching and should lock with ease. Ventouse or vacuum extractor delivery. The types of ventouse cup. We have two types, metal cup and silicone rubber cup. The metal cups most widely used are the bird modification one. These have a central traction chain and a separate vacuum pipe. Different sizes present of 4, 5 and 6 cm sizes, with size of 5 may be suitable for most infants. Recently, a silicone rubber cup have been developed, which is associated with less fetal complication as compared with the rigid cups, and can be used in straightforward occiput anterior position. While in rigid cup is used for malposition and complicated occiput anterior position. The technique of ventouse vaginal delivery. The patient should be in lithotomy position with full dilatation of the cervix and full engagement of the fetal head. Should have good uterine contraction, and we need cooperation of the patient. It means there is a synchronization between the uterine contraction, the push of the patient, and the pulling down of the fetal head, with adequate infiltration of perineum by xylocaine if an episiotomy is planned. The appropriate cup should be chosen and connected to pump. The cup is gently inserted and applied on the sagittal suture of the fetal head 3 cm anterior to the posterior fontanelle. This is known as a flexion point by one hand, while the other hand parts the labia. Then increase the suction to 0.2 kg per square centimeter. After that, we have to recheck that no maternal tissue is caught between the cup and the fetal head. When this is confirmed, the suction then can be increased to 0.6 to 0.8 kg per square centimeter. Traction should be applied along the pelvic abscess downwards at 45 degrees for the duration of contraction. The delivery should be completed within 15 minutes of application. The head, not just the scalp, should descend with each pull. The cup should be reapplied no more than twice. And the forceps should not be tried if failure of delivery by ventouse has occurred. If we use more than one type of instrumental vaginal delivery, this will be associated with more fetal and maternal complications. Finally, we have to avoid rotating the head because it results in severe scalp lacerations. Only pulling down and leaving the head descend with the same manner of mechanism of labor. This figure shows the manner of traction down the maternal pelvic axis. You can see that the head will follow the mechanism of labor by flexion, internal rotation, extension, and then restitution. Just pull down the pelvic abscess without rotation. Contraindications of ventouse. First, face presentation. Second, marked active bleeding from fetal blood sampling site. Third, breech presentation. And fourth, preterm babies when the gestational age less than 34 weeks. Complications of ventouse delivery include trauma to genital tract, laceration to vagina and cervix, leading to severe hemorrhage, caput succedaneum, which is edematous skin pump, cephalhematoma, which is subperiosteal bleed. Serious intracranial injuries and cerebral palsy may occur if multiple attempts at delivery is made with a variety of instruments. مثل ما قلنا لازم ما نستخدم أكثر من نوع من الانسترومنتال فاجينال ديليفري، يا أما نختار الفنتوز أو نختار الفورسبس. من يزيد عدد أنواع الانسترومنتال فاجينال ديليفري وتزيد عدد المحاولات راح تزيد وياها الفيتال complication منها intracranial injuries, cerebral palsy, and other injuries. The second type of instrument is forceps. The types of forceps: first, classical forceps, example, Simpson forceps with longer cephalic curve, used for molded head, and Wrigley forceps with shorter cephalic curve for a molded head. Second type is a special forceps, new one. Example, Piper forceps that is designed for after-coming head in a breech vaginal delivery, and Keelan forceps which lack of pelvic curve for rotational delivery at any station. Also can be used for after-coming head of a breech delivery. This figure showing two types of forceps. The upper one is Simpson forceps and the lower one is Keelan forceps. The technique of forceps vaginal delivery. The head should be fully engaged. The cervix is fully dilated and the position of the head is carefully noted. Evacuation of a bladder is advised. Episiotomy is required. The blades of the forceps should be mashed together. The left-handed blade is inserted first downwards and then inwards, guided by the right hand. The right-handed blade is inserted in the same procedure, and then the blade must look easily and should not be forced to close. The first pull is downwards and then upwards. Complications of forceps delivery. Traumatic vaginal and uterine injuries can result from undue traction and rotatory forceps, which may result in a spiral vaginal laceration or even a bladder injury. Third or fourth degree perineal tears with fecal incontinence, or serious injuries to the baby can occur when excessive force is used or when multiple attempts are made. Indications of forceps instead of ventouse are face presentation, bleeding from fetal blood sampling site after coming head of a breech, delivery before 34 weeks gestation. إذا تلاحظون راح تلقون هاي indications forceps هي نفسها الكونترا indication for ventouse. فإذا كان عندنا مريضة احتاجت الانسترومنتال vaginal delivery وعندها إحدى هذه الانديكيشن مضطرين نستخدم الفورسبس rather than ventouse instruments. This figure shows forceps used for after coming head in a breech vaginal delivery. Cesarean section. Cesarean section refers to an operation that is performed to deliver a baby via the trans-abdominal route. Indications for cesarean section. We have indications that are related to past obstetrical history or current pregnancy events or intrapartum events. These are examples of indications of cesarean section because there are many indications for cesarean section and it should be individualized for each patient. Regarding past obstetrical history, when we have a previous classical cesarean section or interval pelvic floor or anal sphincter repair or previous severe shoulder dystocia with significant neonatal injury. Regarding current pregnancy events, significant fetal disease likely to lead to poor tolerance of labor, monoamniotic twins, placenta previa, obstructive pelvic mass, active primary herpes at onset of labor. Intrapartum events include acute fetal compromise in the first stage of labor, maternal disease for which delay in delivery may compromise the safety of the mother, or absolute cephalopelvic disproportion like in brow presentation. There are many other indications for cesarean section. Preparations for cesarean section. Full informed consent must always be obtained prior to operation. Suprapubic shaving. Bladder should be emptied. Foley's catheter is inserted and remains perioperatively. Pre-medications with antacid is standard, and all patients being transferred to theater must be in the left lateral position with a wedge under the right buttock to prevent supine hypotension and fetal distress. The operating table must be kept in a left lateral tilt position until after the delivery of the baby. Thromboprophylaxis should be considered for all patients and prophylactic antibiotics should be given. The operative procedure. Skin incision is either suprapubic transverse incision or midline vertical incision. Suprapubic transverse incision, which is known as finish teeth incision, is commonly used, has the advantage of improved cosmetic results, decreased analgesia requirements, and thus less postoperative pulmonary compromise and superior wound strength. The other type is midline vertical incision, which provides greater ease of access to the pelvic or intra-abdominal organs and may be enlarged more easily, may be indicated in extreme maternal obesity or suspected other intra-abdominal pathology. Regarding the uterine incisions, there are many types of uterine incisions. Either transverse lower segment uterine incision is used in more than 90% of cesarean section due to easy to repair, reduced blood loss, lower incidence of dehiscence or rupture in subsequent pregnancies. The other type is vertical upper segment uterine incision, also known as classical uterine incision, which is indicated in certain situations because it is difficult to repair, it is associated with severe bleeding, and more incidence of rupture in subsequent pregnancies. You have to know the uterine incisions is different from the skin incisions, So the patient might have finished heel incision with a classical uterine incision, or might have a lower midline skin incision with a transverse lower segment uterine incision. So why we choose the classical uterine incision if it is associated with severe bleeding and higher incidence of uterine rupture in subsequent pregnancies and difficult to repair. There are certain indications for classical uterine incision. These are when the lower segment fibroid preventing the lower segment transverse incision. When I have lower segment dense adhesions in placenta previa with large vessels in the lower segment. Transverse lie with back down and prolapsed arm. Premature pre-labor rupture of membrane associated with poor lower segment and the transverse lie. Conjoined twins, cesarean section in the presence of cervical carcinoma and in postmortem cesarean section. Other types of uterine incision are U-shape, J-shape, or modified classical incision, which is a lower segment but vertical incision. After delivering the baby, placenta and membranes should be delivered by continuous cord traction. Uterine closure, which is either done by single layer or double layer with good hemostasis. Closure with double layer is preferred as it is associated with less scar dehiscence in subsequent pregnancies. Complications of cesarean section. Intraoperative complications. Anesthetic complication, for example, atelectasis, urinary tract damage, bladder and ureteric injury, bowel injury. These are the adjacent organs, including bladder, ureter, and bowel, especially in recurrent cesarean section. Hemorrhage due to vascular injury, like uterine artery injury, or due to uterine atony or placenta previa. There are many maneuvers that may be employed to manage such cases, ranging from by manual compression, infusion of oxytocin, applying compression sutures, to the more radical but life-saving hysterectomy. Other complication is cesarean hysterectomy. This figure showing the anatomy of the female genital tract. You can see that the adjacent organ to the uterus are bladder, bowel, and ureter. We have to see the association between the ureter and the uterine artery. The ureter is passing just below the uterine artery. They say usually is water under the bridge. The water is the ureter and the bridge is the uterine artery. This is why the ureter can be injured when we have injury to the uterine artery as cesarean section. Post-operative complications of cesarean section. Cesarean section is associated with an increased incidence of postpartum hemorrhage, endometritis, chest infection, urinary tract infection, wound infection, Mendelssohn syndrome, and aspiration pneumonia, deep vein thrombosis and pulmonary embolism, increased incidence of placenta previa and placenta accreta in subsequent pregnancies, and finally, delayed contact with baby. Cesarean hysterectomy. This is usually undertaken as a life-saving procedure and as a last resort, but should not be left too late in order to reduce maternal morbidity and mortality. The indications of cesarean hysterectomy are uncontrollable maternal hemorrhage, usually occurring with placenta accreta, uncontrollable uterine atony, uterine rupture, extension of a low transverse incision, leiomyoma preventing uterine closure, and hemostasis. The last subject in this lecture is hematomas, vulval and paravaginal hematomas. By definition, we have infralevator hematoma and supralevator hematoma with regard to levator ani muscle. The infralevator hematoma, those that lie below the levator muscle, including the vulval and perineal hematomas, as well as paravaginal hematomas and those occurring at the ischiorectal fossa. Supralevator hematoma spread out upwards and outwards beneath the broad ligament or partly downwards to bulge into the walls of the upper vagina. These also can track backwards into the retroperitoneal space. The criteria used to define hematoma are hematomas more than 4 cm in diameter. The incidence is 1 per 1,000 deliveries for infralevator hematoma. This figure shows the difference between the infralevator hematoma and supralevator hematoma in its location, position regarding the levator ani muscle. You can see the supralevator hematoma can result in deviation of the uterus to the contralateral side. Causes of infralevator hematoma. The injury is frequently related to episiotomy, but in about 20% of patients, they have intact perineum. Overall, half of the women who develop genital hematoma do so following spontaneous vaginal delivery. The diagnosis, although vulval hematoma is usually obvious, a paravaginal hematoma may be missed with no symptoms until shock develops. Management of infralevator hematoma. Management includes resuscitation and surgical evacuation. If the hematoma is less than 5 cm and not expanding, then observation with ice packs and pressure dressing to limit its expansion and marking the edges of hematoma. But if the hematoma is more than 5 cm or it is expanding, then surgical evacuation is required by incising through vagina to decrease scarring, not just to incise over the skin of vulva, to incise over the vagina or the vaginal edge of the hematoma to decrease scarring. Ligation of the bleeders is done. If no distinct bleeders, then a surgical drain is put or pack can be used. Subperitoneal hematoma or supralevator hematoma. Subperitoneal hematoma or broad ligaments are much less common than genital hematomas. 1 per 20,000 deliveries can be complicated by supralevator hematoma. They follow spontaneous vaginal delivery, cesarean section, or forceps operations. More than 50% of such hematomas are diagnosed immediately, whereas the other half, only present after 24 hours. Symptoms and signs include lower abdominal pain, vaginal bleeding, and deviation of the uterus to one side with hemodynamic instability. Management of subperitoneal hematoma. A conservative approach is recommended with expectant management and resuscitation with blood, plasma, and blood products. If it is not possible to maintain a stable hemodynamic state, prompt surgical exploration is recommended and internal iliac artery or even hysterectomy may be indicated. If you are interested and for more reading, you can go for Obstetrics by 10 teacher, Hackers and Moors Essential for Obstetric and Gynecology, Obstetric and Gynecology, and Evidence-Based Text for MRCOG. Thank you very much and good luck.